Good afternoon, everyone, and welcome to the TxRx Medications for Substance Use Disorder Echo, brought to you by the Center for Substance Use Training and Telementoring, CSTAT by Beval, Texas, in collaboration with UT Health San Antonio Echo. My name is Shreya Prasanna, and I will be facilitating our discussion today. Some housekeeping before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, please click on the speech bubble icon on the navigation bar at the bottom of your window. If you are one of our Bevel Texas providers, please make sure that you identify yourselves during this session. Please stay muted unless you're speaking, and we do encourage you to speak. Your mute button is on the bottom left of your Zoom controls. We also encourage using the chat or raise your hand feature to pose questions or share your perspectives. There are a lot of us in this space, so please keep your comments brief to allow the others a chance to share as well. If you are having connection issues, please privately chat Karen, our Echo ID for assistance. If you'd like to view closed captioning for this session, please navigate the bottom of your Zoom window and select the Show Captions option. If you're having trouble accessing captions, please chat Echo IT. We encourage everyone to join by video, especially for the discussion portion in the latter half of the session. That said, regardless of how you showed up here, we're just as happy you're here to learn alongside us. We are recording these sessions for later distribution on our website. Any information you put in the chat will not be shared in the recordings. Please note that no protected health information is allowed in either the chat or the discussion, and that includes names, emails, addresses, birth dates, or any information that can easily identify an individual. Towards the end of the session, the ECHO team will send out a post-session survey link that we kindly ask you to complete, as it gives us your feedback on how to refine these sessions to better address your priorities. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on transitions between medications for opioid use disorder and alternative dosing strategies, and will be presented by Dr. Nick Christian. Following that, we will discuss a case presented by Dr. Zachary Freeland. We will start with some introductions, followed by didactics, Bevel program announcements, case presentation, and discussion. Thank you all again for joining us today's Echo. In the spirit of all teach, all learn, we look forward to learning alongside all of you, and encourage you all to share your experiences, questions, and insights in today's conversation. And with that, we will do some introductions. Dr. Walker.
Good afternoon, everybody. Crystal Walker, doctorally trained PA. I'm located in Fort Worth, Texas. I'm the director of the medical and clinical services for MHMR of Tarrant County's substance use programs. Welcome.
Thank you so much for joining us. Dr. Chaudhry.
Hello, everyone. My name is Ali, and I'm one of the adolescent addiction medicine providers here at Beval, Texas, at University of Texas Health San Antonio. And I'm glad to be joining you all.
Thank you so much. Dr. Weems.
Hey everybody, John Weems here. I'm an internal medicine doc and addiction medicine specialist here at UT Dell Medical School, and director of addiction medicine at Community Care, big FQHC here in Austin. Looking forward to the talk and the case, and welcome to me.
Thank you so much. Dr. Waklu.
Hi, Siddharth Waklu. I'm faculty at UT Southwestern, addiction psychiatrist by training. I'm a professor of psychiatry here, and director of the Addiction Psychiatry Services and the Addiction Psychiatry Fellowship Director. Welcome, everyone. Look forward to the discussions.
Thank you so much, Dr. Waklu. Dr. Shorter.
Hi, everyone. I'm Daryl Shorter. I'm at the Menger Clinic, where I am the Medical Director of Addiction Services. I'm also an Associate Professor of Psychiatry at Baylor College of Medicine and the Program Director for our Addiction Psychiatry Fellowship. Thanks.
Thank you so much for joining us. Dr. Kowalczyk? Is Dr. Kowalczyk on? All right. All right, we'll come back to her. Dr. Christian.
Yes. Hey, everyone. I'm Nick Christian. I currently work for the National Institute on Drug Abuse. connected through this crew because I did my residency training in Austin and collaborated a lot on some of the shout documents that we'll be going through this afternoon.
Thank you so much. Dr. Freeland.
Hey, Zach Freeland. I'm a hospitalist at Baylor University Medical Center in Dallas, one of the Shout partner sites.
Thank you so much for joining us today. Is Dr. Kowalczyk there? Okay, Dr. Lindsay?
Hey everyone, Adrienne Lindsay, Director for the Center for Substance Use Training and Telementoring at the Be Well Institute at UT Health. And I think I saw Dr. King on as well.
Yeah, I believe he's with a patient right now. All right, with that, we will move on to our didactics. Thank you and welcome everyone again. Dr. Christian, you can take it away whenever you're ready.
Excellent. Let me share my screen. Great. Shreya, can everyone see my slides okay?
Yes.
Awesome. So this afternoon, we're going to talk about transitions between medications, specifically talking about buprenorphine and methadone. And I'll kind of go through my alternative dosing strategies for choosing different buprenorphine start regimens. Just some background. I did my addiction medicine training at Yale. In their program, I got a lot of experience. They have a primary care clinic in a methadone clinic. And so we did a lot of transitions between methadone to buprenorphine in that clinical environment. Additionally, I've done a lot of street outreach. So some of the counseling that or the slides that I'll discuss presenting some of the counseling that I provide patients are mainly focused on that context of like, how do you empower folks to make the best decision and when they're in an environment where they don't have very many resources for starting buprenorphine. So I just have to disclose that I currently work for the National Institutes of Health, but this presentation was prepared by myself in my own personal capacity and doesn't reflect the views of my employer. So the first learning objective is going to be to identify strategies to transition patients from buprenorphine to methadone. We'll then cover a case to look at best practices for transitioning patients from methadone to buprenorphine. And then we'll, in the process, talk about how to analyze and apply different dosing strategies for initiating buprenorphine. I will be abbreviating that as BUP throughout the slide, or BNX for buprenorphine naloxone. And I just want to draw everyone's attention to all the resources that are available in the Supporting Hospital Opioid Use Disorder Treatment Shout Texas website. I will specifically be reviewing the MOUD Shared Decision Making and Medication Transition Guide, as well as the alternative buprenorphine initiation strategies. But there's some other gems in here as well for those of you who might work in the inpatient hospital setting that don't prescribe methadone all that often. This methadone quick start guide is also incredibly helpful. And some of these this QR code should take you directly to this website. And I will be sending out my slides to everyone. So don't feel rushed to screenshot everything. You'll get all of these hopefully afterwards. And I hope today can be interactive. We're going to discuss a case here. We'll discuss two cases, both in the inpatient setting and in the outpatient setting. So we have JD here. He's a 36-year-old male. He was recently incarcerated. He has a history of opioid use disorder. He takes buprenorphine naloxone, 16.2 milligrams daily. He had been taking it in that way in the past. So let's think about this case in the inpatient setting. Let's say that JD comes into the emergency department and our colleagues there started him on 16.2 milligrams buprenorphine, and he's doing quite well. However, you get called in to see the patient because you realize that the patient was actually brought in by the Department of Justice, and he's going to be transferring to a correctional facility that doesn't have access to buprenorphine. However, they do have access to methadone. So we're stuck based on the patient's discharge plan of he can no longer be on buprenorphine, but he could potentially be transitioned to methadone. He was admitted for soft tissue infection, so you're going to be treating him with antibiotics. He's going to come into the hospital for at least a couple of days. I'm curious to hear how would folks approach this for someone who received buprenorphine in the ED, being admitted for a couple of days for soft tissue infection, but the potential for being transferred to the carceral setting at discharge. And Tria, I can't see the chat in case folks are commenting there, unfortunately. Oh, wait, here we go. Now I've got the chat. Well, in case everyone's an outpatient provider here, I'll go ahead and present the alternative outpatient setting. And I wanted to present both because mainly to highlight that there are so many different reasons why people want to transition from one medication to the other. And so here's another situation that I have seen. JD comes into the clinic. He last took his buprenorphine this morning, but he says that it's not holding him. He feels like he's about to have a return to use, and he wants to go back on methadone. And we got a couple of comments in the chat box. So confirm that they can continue in jail. So in the inpatient setting, confirm that they could continue the methadone in jail. If they're on board, start the methadone. Safest place to titrate is in the hospital. Yes. I'd ask the patient if he's okay with maybe a methadone plan when he goes to county. He might not want that. Absolutely. So first step in all these situations is really to elicit more information from the patient. If they aren't interested in a transition, you should maybe inquire why. And really, the main reason to initiate a transition should always be through shared decision making. It should be the patient's desire to switch, unless there's a situation like in this instance where they're going to transition to a place where it's not an option to continue on buprenorphine. Here on the East Coast, we have much more opportunities to consider Sublocade in folks prior to potentially going into the prison system. I don't know what that's looking like in y'all's neck of the woods, but that's also an option potentially in the inpatient setting here. But like Dr. Weems said, get started with the methadone. That's the switch from buprenorphine to methadone is actually quite simple. You just start the methadone and you stop buprenorphine. Some things to consider in the outpatient setting, though, especially if you're a PCP working in a place where you don't have close ties to a methadone treatment program, like it's really important to make sure you're reaching out to those programs. So most of them will make sure folks provide a urine drug sample prior to enrolling them on methadone. And if they see that the patient has buprenorphine in their system, they might not start them on methadone that day. So I would encourage all folks, both in the inpatient setting and in the outpatient setting, to make sure that we're calling and checking base with these facilities to make sure that they can continue treatment, make sure that we have as much data available so that there's no delays in care and getting them the treatment that they need. And I just wanted to point out the SHOUT document, this methadone administration quick start guide, for those of you who work in the hospital who might start methadone. I always recommend folks, you start, the mantra is always low and slow, but we're getting more and more evidence that maybe in the inpatient setting when folks are being observed, that it's actually quite safe to consider a more rapid up titration than what you can do in the outpatient setting. At the end, I have some resources. There's a rapid titration guideline from out in Oregon. So that's available at the end of this slide deck. This is the current recommendation, though, is to start with 30 milligrams. You can give an additional 10 same day that evening if people are still having symptoms. But really, from bup to methadone, quite simple. You just start it and make sure that we're ensuring that folks are getting connected to the appropriate care and making sure that folks aren't going to run into insurance or other barriers to starting treatment. Any questions about starting doing the transition from buprenorphine to methadone. That's
I,
the simple one.
I have a question actually, and I noticed Sandra Flores in the chat asked it as well. So we have an outpatient OTP clinic, and we have gone from methadone to buprenorphine, or I'm sorry, buprenorphine to methadone many times, as you're saying, without any problems. But what about the naltrexone? And you don't have to wait any certain amount of time for that to be out of their system?
So just to clarify, so it looks like Sandra's question's about buprenorphine naloxone. Are you talking about transitioning
I'm
from
sorry, I just said
naltrexone?
the wrong thing.
Okay, no, both are great questions. That's why I just wanted to make sure that I clarified. The buprenorphine naloxone. This brings up a great point that maybe philosophically I can briefly discuss. So the buprenorphine naloxone, the component that is actually that causes precipitated withdrawal isn't the naloxone. It is actually the buprenorphine. The naloxone is really only there as a deterrent, so that people don't snort or inject the medication, and it reduces, for lack of better words, abuse potential of the medication. And so the reason why we get precipitated withdrawal is that the buprenorphine is what we call a partial agonist, as opposed to methadone, the full agonist. How I describe this to patients, partial agonism just means that when it binds to the receptor, it's like a light dimmer switch. It just turns that dimmer switch up to about 75% with buprenorphine, whereas with methadone, when it binds to the receptor, it turns the dimmer switch up 100%. So all that you're doing when you're going from buprenorphine naloxone to methadone is you're turning the dimmer switch from 75% up to 100%. Patients don't feel bad when that happens. So people typically do just fine and there's no threat of precipitated withdrawal in that situation, going from bup naloxone to methadone. Now, the inverse, which we will go into in this next case, is very different. When you have methadone in your system, the light switch is turned up 100%. You provide partial agonism, and that partial agonist binds to the receptor more tightly, and not necessarily more tightly, but it's going to kick off anything else. It has a high affinity for the opioid receptor, so it's going to kick off other things that are on the opioid receptor. And so what happens then when you have methadone in your system, you're at 100%, you give the buprenorphine immediately, and so you're going from 100% down to 75 to 60%. And when that happens quickly, you see the patients feel the light dimming very quickly, and that is what we call precipitated withdrawal. People feel that difference. And what we'll get to later is discussing low dose initiation strategies. And really the goal there is that just like in the movie theaters, how they turn the dimmer switch down very slowly, so you don't even notice at first that the lights are going down. That's the goal of a low dose initiation, is you're slowly turning the dimmer switch down, as opposed to someone's on methadone, you give a bunch of buprenorphine, you're going to turn that dimmer switch down very quickly, and it's going to feel like precipitated withdrawal. So that's a great question. Thank you so much for asking it. Did I help answer that or clarify any concerns there?
You did. I still want to clarify though. So, and I really appreciate explaining about the naloxone, how that's not what causes the withdrawal. So we don't have to worry also then with the naltrexone, or is that different?
Naltrexone is very different.
Okay.
Yeah, so
well, then don't worry about that. I don't want to get ahead of you.
Yeah. The naltrexone, which we won't be talking about today, is a full opioid antagonist. And because it's a full antagonist, if you have, well, we can use the same analogy. So you have buprenorphine, dimmer switches up to 75%. You give naltrexone, all of a sudden you're going from 75% to zero real quick. Like, just think of naltrexone as being a brake on any opioid agonism. Naltrexone will certainly cause precipitated withdrawal in folks if you give it too early, if they're on buprenorphine or if they're on methadone. And the reason why this is different, I won't go into all the details, but buprenorphine naloxone, when you take it sublingually, it goes through first pass metabolism, and that is what eliminates the naloxone. And that's why the naloxone component doesn't have any effect in your body when you take it as prescribed. As an aside, that's also why maybe there might be some evidence that in folks with liver problems that aren't able to metabolize the naloxone component, maybe you might want to consider a monoproduct in those cases, a monoproduct being buprenorphine without the naloxone. But yes, thank you so much, Jasmine. That was a great question. I see a hand from Carla.
I'm just reading what it says, and people with prolonged QT can't be on methadone. Does it make the QT wave interval longer, or what happens if somebody with prolonged QT goes on methadone?
I thank you so much for asking. That wasn't something I was going to fully dive into. There certainly are certain patients that would be higher risk for transitioning to methadone. People with a significant cardiac history with a prolonged QT interval. That is specifically something that we see on EKGs, and that methadone is definitely a common bad guy in regard to making the QT interval more prolonged. And there's a lot of debate about how significant this is, but the bottom line is that the more prolonged your QT interval, the more likely you could have significant heart arrhythmias, in particular torsades. How often this actually happens is still, there's not great literature out there, but most people use the cutoff of about between 450 and 500 for the QT interval. People that are more prolonged than that, then you might want to consider transitioning them from their methadone to something like buprenorphine. And I have done that several times in the hospital and in the outpatient setting. I had one patient who had went into ventricular tachycardia, had a cardiac arrest, was on methadone. No one was sure what caused it. So we were like, you know what, it's probably safest to consider switching you to buprenorphine. So Carla, thank you for pointing that out. And I see another hand.
You said earlier that this one is right. It's not so awesome. My understanding that the binding of buprenorphine to the nucleus is so tight that naloxone cannot get binding. So I have patients, if they don't get drug likeness, one of the I'm sure that maybe or even depression is not injected. The binding of buprenorphine is so tight.
Dr. Wacklow, I wonder if you could put that your question or comment in the chat box. For some reason, your microphone, was really challenging for me to make out any of the words. Thank you. I'll keep going because I think I only have about 5 more minutes, and we got the more exciting content to cover here. And then if there's time for questions and discussion at the end, we can definitely entertain those. So switching from methadone to buprenorphine. So we have AM. She's a 42-year-old female. She has a history of anxiety and depression. She has opioid use disorder. She's on methadone, 145 milligrams. So let's say an example in the inpatient setting, she presented with chest pain, dyspnea, fevers, was diagnosed with endocarditis, is going to be admitted to the hospital for a while, currently on IV antibiotics. She recently had a child. And she expresses to the team that, hey, methadone's just inconvenient for me. I don't want to have to go to a clinic every day. I'm interested in starting buprenorphine. We could take the same patient, put her in the outpatient setting. So she is dosing at her local opioid treatment program, 145 milligrams methadone daily. She's about to get a job, but she also has a 2-week-long vacation coming up. She's going to go to the Caribbean in about 2 months. And so she wants to know, how is it possible for me to switch to a medication like buprenorphine where I don't have to be dosed every day? So these are just 2 examples of situations where patients just at certain points in their life, switching to buprenorphine is just more convenient to them. And it's a very patient-driven approach. They're coming to you asking for these changes. So how would you approach deciding how to make this transition from methadone to buprenorphine? I'm curious to hear if any folks have experience in this space, either inpatient setting or the outpatient setting.
As an outpatient setting, we tend to, and I don't know if it would be different with someone who's just had a child, but we tend to have them take their last dose on a Friday. and of methadone, and then come in on Monday morning for their buprenorphine.
Awesome. Thank you for that. That's a highly effective approach. Typically, just looking at Crystal Walker's comment, yes, thank you for commenting on the prior question. Tanya.
Yes. Okay. So I have a question. That was interesting. They're on 145 milligrams of methadone, and they're going to go 2 days without taking 145 milligrams of methadone and then bupe on a Monday. I mean, tell me, I guess from my patient experience, you're asking me to go from 145 milligrams and go 2 days with absolutely nothing, and then come in on Monday and take bupe. That's a pretty high dose to just stop and then get on bupe. Well, I mean, and I say that because normally what we'll do is we'll do a slow taper, and we'll do maybe 5 to 10 milligrams a day based on their comfort zone. And then when our physicians get to about, and it depends on the doctor, but when they get to about 60 milligrams, then they'll start the microdosing of 2 milligrams bupe and then raising that bupe up from there. But that 145 and stop like that, I see that as being really, I don't even see do it. You know what I mean? I can just see my client going, what? You know?
Thank you for sharing that, Tanya, because that's something that I haven't had experience doing, like having folks start with that high of a dose. And I would certainly want to evaluate, and I would imagine that the program does evaluate the patient that Monday. If they don't look like they're in enough withdrawal, then you would probably wait an additional day before starting, or instruct the patient, like if you're getting these amount of symptoms, or give them some sort of COWS rating so that they know when it's appropriate to start the buprenorphine. But what I have done, so just a bird's eye view, when I'm discussing with patients the different strategies for starting buprenorphine, my first thought is, okay, should we provide a non-overlap strategy, or is it possible to provide an overlap strategy? Let me explain. So the non-overlap strategy is essentially means that you have to provide a washout period. You need to create enough time for the opioid in their system to potentially wash out. That the standard non-overlap protocol that almost everyone that prescribes buprenorphine is familiar with is you wait until someone is in withdrawal, then you start with 4 to 8 milligrams. You can give an additional 48 milligrams if they tolerate it. Or I consider a macrodose strategy also in the standard non-overlap, where you're waiting for people to start to withdraw, and then you hit them with a large dose of buprenorphine. To me, it's the simplest. You just have to be careful regarding potentially precipitating withdrawal. There's also this strategy that I'm not going to go into, but y'all should read about this. This is from UPenn. Some doctors there have created a strategy that they say has been highly effective. I still haven't seen them publish it, where you only have to wait 6 hours, and then you're dosing buprenorphine in low doses every 2 hours. And so every 2 hours for the first 18 hours, you're giving yourself buprenorphine. And then eventually by day 2, you're on 8 milligrams BID of buprenorphine. These QR codes will get you to more information on these things. So I'm not going to go into those details. What I think about when I'm counseling patients is that I think that this strategy, a standard strategy, is best if the patient is using street drugs, if they aren't going to have access to a full agonist, or if it's just difficult to communicate with the patient. I'll go into why I think that is important as I talk about the low dose overlap protocol, which is essentially what we call the low dose initiation, where someone is continuing the methadone and you're slowly introducing buprenorphine while they're continuing the same methadone dose, and you're doing that for 7 days, or 7 days or 5 days. You pick your low dose protocol that works best for you. But I can tell you from my personal experience, I have used this protocol for patients on methadone doses up to 140 milligrams, and people tolerated it just fine. The only reason why it works, though, in the outpatient setting is because someone's continuing a stable full agonist. And also, I had patients who were able to call me when they had concerns, when they started to not feel well. If people don't feel well, sometimes you have to prolong at that rate. You want to keep the dimmer switch where it is. You don't want to turn it down anymore. And so it requires that your patients have a phone and that they're in a stable environment to work with you on that. But to me, the low dose overlap, especially with methadone, is probably the best way to go, especially if the patient's unable to tolerate withdrawal. And you can use the same approach in the inpatient setting as well. And so briefly to recap, and then I'll check with Shreya if we have any more time here. I first decide if the patient can tolerate withdrawal, and that helps me decide if someone should be on a non-overlap versus an overlap protocol. Someone who really doesn't want to go through the withdrawal experience, that's when I would consider going through an overlap protocol. If you choose overlap, you can decide the number of days that you want to, of the protocol you want to use. There's a 5-day, there's a 7-day. We have some of these strategies. The 7-day one is in the alternative buprenorphine initiation guide here. But if you choose the non-overlap strategy, you just kind of want to decide how big of a dose do I think they can tolerate at first? How long do I think that they can wait until they start the buprenorphine? If they can't wait for very long, then you can try that every 2-hour dosing strategy where you only need a 6-hour washout period. I call that the rapid overlap. Or you could try a macro dose or just a standard dosing protocol. So that was all the content I wanted to cover, but I wanted to highlight, in case people have questions, that sometimes it is hard to do the low dose initiation strategy in the hospital because pharmacists don't like cutting sublingual strips. This is a way to use Belbuca instead of the sublingual, instead of the buprenorphine naloxone strips. There's also, this is an outpatient way to potentially do this between methadone to buprenorphine. There's a bunch of reference to several other strategies, 3-day overlap protocols here, as well as an overview of when to consider high dose, low dose, and those sorts of protocols. So I think at this point in time, I will stop, look in the chat box. Shreya, let us know how much time we have here.
Thank you so much, Dr. Christian. We are pretty much close to time. Maybe we may have time for a question or two at the most. I see a question here from Megan. When do you start it? Like, is there a methadone dose they should be down to?
So there was a study that I was just reading again back in like early 2000s that showed that patients transitioning from methadone to buprenorphine, that if their dose is 70 milligrams or less, they do better. And so I think that there is some truth to, if you can slowly decrease the methadone, it's going to be easier for everyone. Some patients, if they don't want to go through the withdrawal of potentially slowly titrating their medication, then you might want to consider doing a low dose overlap strategy. The other huge box of tools that we didn't get to discuss today are all of the adjunctive medications to use to help supplement folks that are going through withdrawal. So you always want to make sure you're considering things like an alpha-2 blocker like clonidine, making sure that you're considering things like, a lot of folks just get really bad anxiety with the thought of even transitioning. And so considering low amounts of intermittent benzodiazepines, I think, are really effective. Of course, you want to make sure you're counseling folks that, hey, this isn't a long-term medicine. This is to aid in your transition. But I have found that diazepam, lorazepam, both are highly effective to help folks transition because there's just a lot of anxiety around the switch. You're working with a bunch of different, both not only like physiologic dependence, but some behavioral connection to your medication. And that behavioral piece is something that we often overlook. And giving them a benzodiazepine can, I think, help a lot with that.
Dr. Kowalczyk.
Yes, thanks. I just was wondering on the concurrent initiation. So you have them, you starting the low doses while they're continuing on the methadone. And it says the methadone continues up until they're on 3 or 24 milligrams a day. is that methadone being tapered during that time, or they just stay on their baseline dose and then, it's an abrupt cessation?
Yeah, so they're usually staying on the same dose for days 1 through 6. And then once you get more than 16 milligrams or right at 16 milligrams of buprenorphine in someone's system, if they've tolerated that, you're more than likely in the clear. And that's because we think that once you get to 16 milligrams of bup, you're binding greater than like 95% of the opioid receptors in someone's body. And so if they've tolerated that dose, then they're probably doing okay.
Thank you so much, Dr. Christian. And thank you all for a really interactive session today. In the interest of time, we will move on to the next part of our session, but please do keep the questions coming. I'm sure Dr. Christian can answer them in the chat. Karen, if you could please bring up the announcements from Be Well. Thank you so much. To claim your CME credits, you must text by midnight tonight. Please text attend 1009-8096 to 844-502-1338 to record your attendance and get your CME credits. Next slide, please. The 2025 Texas Substance Use Symposium is officially open for registration. This free event will feature complimentary continuing education curriculum, interactive panel discussions, and professional networking with national and Texas-based substance use disorder experts. To register, please visit texas.org. Next slide. We're also open to sponsors and exhibitors. Texas will be taking place on February 27th and 28th in El Paso, Texas. If you're interested in learning more on how to become a sponsor or an exhibitor, please visit us at texas.org/sponsor Texas, and we will drop this link in the chat as well. Next slide. Please join us for our next webinar on January 10th with Dr. John Weems. We will be dropping the registration link for this in the chat. Next slide. And finally, our next TxRx session will be on Thursday, January 9th at 12 noon. So please do join us. And with that, we will move on to our case for today. Karen, if you could please bring up the case, and Dr. Freeland, you can take it away whenever you're ready.
All right, thank you. So just a little bit of background here at Baylor University Medical Center. We started an opioid use disorder consult service that's based in the Department of Hospital Medicine. So we have a team of about seven hospitalists and 3 APPs who will see patients hospital-wide on a consultant basis and start MOUD and try to connect patients to outpatient treatment. So this is a case that I thought would hopefully dovetail well with Dr. Christian's didactic. I'll start with the 3 questions. One is just kind of a general question about taking care of patients with OUD in the hospital, but how do you handle patients who are either found with drug paraphernalia in their room or who are witnessed using substances in the hospital? Second question is, how can we better ensure outpatient follow-up when patients are discharged to rehab facilities as opposed to the community? And then how can we better educate primary care providers about buprenorphine and help empower them to prescribe? So onto the case. This was a 43-year-old white man who was admitted to the trauma surgery service after a motor vehicle accident. This was at I'll just, if you don't mind, I'll skip ahead to the kind of case discussion at the very end, just for a little bit more background. But he was in a motorcycle accident at highway speed, had a number of visceral injuries like kidney and spleen lacerations. He had several fractures, including long bone fractures and pelvic fractures. and was in the hospital for upwards of a month. Underwent a couple of surgeries, and had a history of heroin use, and the trauma surgery service was having difficulty controlling his pain and getting him weaned, and consulted our team at that point. So we weren't brought on board until about 28 days into his hospital stay. Sorry to make you scroll back and forth. I'll kind of go back up to the top now, back to his kind of history of substance use disorders. So as I mentioned, had a long history of heroin and fentanyl use by injection. It was a little bit hard to get a history from. Initially, our team denied using illicit opioids, said he was only taking pills, but then later admitted to it. We didn't really quantify exactly how much he was using. Also denied using cocaine, but it came up on a urine drug screen. He did endorse smoking about 1.5 packs of cigarettes a day. Endorsed some light alcohol use. Of note, a urine ethanol screen or a blood ethanol screen on admission was negative, suggesting that that probably wasn't a big issue in his motor vehicle accident. Denied using marijuana, but again, that did come up on his urine drug screen. He was interestingly prescribed Adderall, and I'll come back to that in a little bit. But no, as far as we know, no illicit methamphetamine use. No to, and then also was prescribed alprazolam, again, denied illicit benzodiazepine use, and then no to the other substances listed there. So the primary diagnosis with opioid use disorder, with probably also concurrent cocaine use disorder and tobacco use disorder as well. He had his only history of treatment for OUD was some buprenorphine in the remote past. We didn't get a lot of details about that. He'd never had any kind of inpatient treatment. If you can scroll down onto the kind of social conditions, he was a veteran, although wasn't engaged in any particular services through the VA for veterans. He had a very limited support system. He had a girlfriend, but she was, I'm sorry, this individual was unsheltered. Girlfriend was also unsheltered. He did have some family, but they weren't really in a position to offer him any support at that time. Didn't have any transportation. Maybe was currently employed. We kind of got conflicting reports about that. And then he denied having any psychiatric history, although, as I mentioned earlier, he was prescribed both Adderall and Xanax. So we reviewed the prescription monitoring program, and consistent with the patient's report, he was pretty consistently prescribed on a monthly basis, both alprazolam 2 milligrams BID and Adderall 30 milligrams BID. And then it had a couple scripts for like Percocet and Norco here and there. And these were all prescribed by the patient's primary care provider. So then back to the kind of clinical course. So when we were brought on board, the patient was getting oral oxycodone and tramadol around the clock. Daily doses were around oxycodone 20 to 30 milligrams a day and tramadol 100 to 150 milligrams a day, which really were not particularly high doses. He had been actually weaned off of IV opioids at that point, but kind of against his will, and his pain was not well controlled. It was anticipated that he was going to need to go to an inpatient rehab facility. So methadone kind of was not an option. So we did talk with him about starting buprenorphine, and he was interested, but was apprehensive because he had just very minimal past experience. He was apprehensive about making stopping all full agonists kind of cold turkey and making that switch. But we were able to persuade him to do it in a gradual fashion using a low dose or microinduction approach. Is it okay if I share my screen? Let me see if this works. Maybe I can't. Let's see. So this is a protocol that we devised, very similar to one of the ones that Dr. Christian showed, that we devised with our inpatient pharmacists for low dose or microinduction in the hospital. And as you can see, it starts out, so because of the issue that Dr. Christian alluded to with having trouble coming up with sub-milligram doses of buprenorphine, because the pharmacists aren't enthusiastic about cutting the films into quarters and eighths, and because the tablets can't really be accurately divided because they're kind of disintegrating tablets. So they were able to obtain Belbuca, which is a branded formulation of buprenorphine that comes in smaller doses as low as 75 micrograms. So as you can see with this protocol, it starts out with just 300 micrograms once on the first day, and then twice on the second day, and then goes up to 450 twice, and then 3 times a day on days 3 and 4, and then it switches to the regular generic buprenorphine or Subutex tablets. And up until that day 7, the full agonists are left on board. So this is what we did. And I think actually we were, like, he tolerated it very well. We were actually able to kind of skip a couple days just in the interest of making that transition quicker, because he was about ready to transition to inpatient rehab at that point. And we were able to successfully get him up to 8 milligrams BID. And at that point, he had really just kind of stopped asking for the oxycodone and the tramadol, except very sparingly. And we were able to stop those at that point without any loss of pain control. And the patient was eventually discharged to inpatient rehab on that 8 milligram BID dose. And so this was we considered and we can go back to the case form. But we thought this was a successful use of our low dose induction protocol, which was relatively new at this point. One kind of, so we were able to get the physician at the inpatient rehab to continue the buprenorphine. When I look at the PMP, it doesn't look like it was ever filled anywhere after he was discharged from the inpatient rehab, and we weren't able to follow up to see kind of what happened. I'm not sure if he was referred to an outpatient clinic or if he ever followed up or exactly what happened. But he was at least able to kind of complete his treatment course and recover from his accident. Another kind of sort of frustrating thing in this case was that, as I'd said, the patient's primary care provider had been prescribing these 2 controlled substances, and I was able to reach out to him by phone. And he was unaware of the heroin use. He said that he was not experienced or comfortable prescribing buprenorphine. When I look at the PMP, it looks like the patient is continuing to get the Adderall and the Xanax from his PCP, but not buprenorphine. So I don't know. I sort of wanted to be able to sort of persuade the PCP to at least consider prescribing buprenorphine once he was out of the inpatient rehab. So I'm not sure if that conversation was ever had or if it was just something that the PCP wasn't willing to consider doing. So that's all I've got. I'm curious to see what the community thinks about. And sorry, regarding that first question, I didn't mention it, but prior to us getting on board, this patient had been found with syringes and other drug paraphernalia in his room. Again, his pain hadn't been controlled, and the suspicion was that he was using heroin or fentanyl there in the hospital to help with his pain control and uncontrolled withdrawal symptoms, probably. And that wasn't an issue kind of after we got him stabilized on the buprenorphine, but just curious to see how anybody else sort of handles that situation.
Thank you so much, Dr. Freeland, for this wonderful case that you've shared with us. I'm going to open up the floor for any questions or comments from our learning community. Dr. Vaklu.
Reactions. That's you can see the charts of people. I sincerely hope that you will.
Dr. Vaklu, you're breaking up. Would it be possible for you to type it out? For some reason, we have some audio difficulties. In the meanwhile, I see a comment here from Dr. Chaudhry. So the chance success of a low-dose overlap induction of buprenorphine are 80% if the patient is titrated down to 80 milligram of methadone before starting bup. Did you want to comment on that, Dr. Chaudhry?
Oh yeah, this comment was for the
Oh,
didactic session.
okay.
So
Okay. No worries. Okay. Any other questions or comments?
I just thought that using those buccal film was a really good idea, and didn't really myself. I don't really think about that very often. Mostly from an outpatient perspective. But that's a great solution to having those smaller doses and getting by the pharmacist's hesitation for cutting things into little pieces. So which is understandable. So yeah, good idea.
yeah, I think one question I wanted to ask, and this might not be related to the science of it, but like, how did you get the insurance approval for those things? Because the Belbuca thing is like only approved for like chronic pain. So how did you get around to getting the hospital to allow it for a bup induction?
Yeah, good question. You're right. So it is an expensive branded product. Basically, the way that we were able to sort of make the argument for it was that it's only going to be used in these select cases where we're trying to transition somebody from either full agonists or including methadone to buprenorphine, and it's only going to be used for these first 4 days in that protocol. So it's going to be very limited for each patient, and the total expense per patient should be relatively low, maybe a few $100s, and can potentially make their hospital course shorter and much smoother and avoid a lot of pain and suffering.
Yeah, a couple of days of that stuff is a drop in the bucket compared. Especially for this guy. Oh my goodness, that was a fortune that he ended up spending in the hospital.
Yeah.
This is Alicia, Dr. Kowalchuk, and I just wanted to thank you for bringing this case and highlighting these ongoing challenges. We have a primary care provider here who is comfortable enough to routinely prescribe benzodiazepine it appears, without a diagnosed anxiety disorder, and a controlled stimulant, again, without a diagnosed ADHD diagnosis to justify that, and yet seems to be reluctant to write for buprenorphine to treat opiate use disorder, which I would argue probably has a much lower risk, particularly compared to alprazolam, of overdose, and even in a situation where this patient seems to be using some other things along with their prescribed medication. So I think it just highlights that disconnect between the risk perception that primary care providers may still carry about buprenorphine products, and some opportunity for additional messaging.
Yeah, I think the hope is that with the new training requirement from the DEA, that eventually that kind of knowledge will trickle down. But I think there's always going to be a lot of, or at least some degree of inertia in the community.
Thank you so much.
The other thing, this is Alicia, Dr. Kowalczyk again. I just wanted to mention, I do note, in your presentation, you discussed him not being engaged with the VA. I don't know if that's because he's just not eligible from whatever his service was and engagement was, or he hasn't gone through the eligibility process. But that might be a resource for him to get ongoing outpatient substance use disorder treatment, without other resources that he may not have considered or been tapped into.
Yeah, that's a good point. That definitely is something that the VA is very good about. I can't remember if we explored that at all, or like what his level of service connectedness was, or if he was eligible for services or not. But that's a good point.
Well, thank you so much, Dr. Freeland. And Dr. Kowalczyk, may I request you to please summarize today's session?
Yes, thanks so much. So we heard in the first half of the session about how to safely help guide our patients who want to transition from buprenorphine onto methadone, a little less tricky than transitioning from methadone to buprenorphine, and several different protocols and approaches to take both in an inpatient and an ambulatory or outpatient setting. And then our case was about a 43-year-old male who was hospitalized for an extended period with significant traumas related to an MVA, with the team coming on board around his substance use disorder problem about a month into his hospital stay. This person has polysubstance use, but clear opiate use disorder, also on prescription benzodiazepines and stimulants, as per PMP review and self-report and UDS screening. Their significant pain related to their injuries and recovery that was initially managed with opioids was able to successfully be managed along with their use disorder with a transition in the hospital using a low dose or microdose induction protocol with buprenorphine, using a buccal-based product. And challenges remaining for this case were that in the transition to the intensive inpatient rehab facility for physical rehabilitation, there was a disconnect on discharge that appears to have happened with them not continuing on buprenorphine long-term, and those challenges. And then the challenges noted of primary care providers being comfortable and having some experience with writing for other controlled substances, such as benzodiazepines and stimulants, but seemingly less comfortable with prescribing a partial opioid agonist like buprenorphine in caring for their patients' opiate use disorders.
Thank you so much, Dr. Kowalczyk, for that summary. And thank you again, Dr. Christian, for that wonderful presentation, and Dr. Freeland for bringing this case to us. And thank you all for joining us today and making this session so interactive. As a reminder to earn CE credits, please text the activity code 1009 8096 to 844-502-1338 by midnight tonight. We also request you to complete the post-session survey using the link in the chat. The survey link will be open for 1 week. If you would like to present a case, please email cstat@utisca.edu. We look forward to seeing you at our next session in the new year on January 9th at 12 noon Central. Have a wonderful rest of your day and wish you a wonderful holiday season. Thank you so much. Take care. Bye-bye.